the red dye solution was the pressure injected from root pulp chamber. Dye solution cannot penetrate the Caries region to upper side. The vitrokite, that is a precursor of hydroxyapatite crystal, deposit in dentinal tubes. It functions defense. So we need to be careful to preserve this protective layer. Otherwise, post-operative hypersensitivity is induced by removing this layer. Then we need to distinguish between two layers to remove only infected dentin. So we do the selective caries removal to firm dentin, SRFD. There are some arguments about how to remove caries dentin. There are some identification methods for infected dentin. Hardness by tactile means, discoloration by visual means, and stain by dye. Let's see the mood hardness of acute dentin caries and arrested dentin caries. Red line is the caries dentin. Green line is sound dentin. Okay, of course, we can see the different behavior between them. Of course, acute dentin is soft and the arrested dentin is hard. Moreover, in case of acute dentin caries, bacterial front here is far from the discoloration front and softening front. They're around maybe the 1.5 millimeter. On the other hand, in arrested dentin caries, they are very close, around 0.5 millimeter. So we can say, in case of arrested dentin caries, the hardness and discoloration can be indicator of for the cutting, removing the infected dentin. So indicated, actually the indicator of the bacterial front. It's okay. But in case of acute dentin caries, they cannot be indicator. So Professor Fusayama in TMDU developed the caries detector dye that can stain only the infected dentin in 1983. In Japan, the caries detector dye is recognized as the most reliable because dye infiltrates moderately into the collapsed dentin structure by decalcification. The dye is acid red. The molecular weight of the solvent, that is propylene glycol or polypropylene glycol, regulates its infiltration into exposed collagen network in infected dentin. It is used for the careful caries removal to avoid unnecessary cutting. The staining and immediate water washing are repeated until getting not staining anymore. Actually, the staining, immediate water washing, and cutting is the repetition. Okay. We know that regarding the accuracy of caries detector dye, there are many arguments. It was reported that 52% of the completed caries, the completed cavity showed stained in some part of the enamel dentin junction. So some people said in their paper that caries detector dye should not be used to dictate caries dentin removal, and conventional tactile and optical criteria are good assessments. The paper published in Journal of Dentistry in 2012 became the basis for the clinical guideline for caries removal in Japan. They recommended that by using caries detector dye, infected dentin can be removed securely and access to the preparation can be avoided. Moreover, they also mention about hardness and color. To the question if hardness and color are reliable diagnostic criteria or not, they answer that microbial count in case of hard callous dentin is significantly lower than in soft callous dentin. On the other hand, when strongly discolored callous dentin is removed, transparent layer free from microbial infection and ranging from amber to flaxen is observed. Accordingly, it is recommended that callous dentin should be removed using a sharp spoon excavator or roundabout at low speed, taking both hardness and color into consideration. It is reported that sharp spoon excavator can remove callous dentin having up to around 20 kHn. That is around maximum hardness of infected dentin. Recently, the Ireland group reported minimally invasive selective callus removal, a clinical guideline. Now, the minimally invasive callus removal is for avoiding pulp exposure and making repeated restoration cycle stop. In the paper, they mention about 2019 European Society of Endodontics, ESE, position the statement that definite, define two selective callus excavation endpoints. One is selective removal of firm dentin, SRFD. We always apply this method for shallow or moderate deep lesion. Pulpal, the wall should be laterally or far. In case of deep lesion, existing pulpal third or quarter of dentin, selective the removal of soft dentin, SRSD, is applied. Pulpal soft dentin caries is left. In both cases, cavity margin, usually enamel margin should be caries-free, and peripheral dentin wall should be sound and scratchy. It is because after caries removal, composite resin restoration is often selected, and tensile bond strengths of adhesion system to infected dentin and affected dentin are less than sound dentin. The previous data showed for infected dentin, it is around 10 megapascal, affected dentin around 20 megapascal, and sound dentin 40 to 50 megapascal. So enamel and peripheral dentin wall should be sound. Moreover, they mention two available selective caries removal methods in deep caries. One is selective caries removal in one stage to soft dentin, and other one is stepwise excavation, 2 stages. In Japan, stepwise excavation is very popular in deep caries. In the first stage is selective caries removal to soft dentin, and in second stage, re-entry after 6 to 12 months and remove to firm dentin. In the schema, B is non-selective caries removal. It has very high risk to get pulp exposure. C is stepwise excavation, the first stage. It still has a risk of pulp exposure at the second stage. D is the selective caries removal to soft dentin, one stage. It has very less possibility to get pulp exposure. This is the case of the stepwise excavation. Remained the callus dentin was remineralized after sterilization by calcium hydroxide due to a high alkalinity. So even infected dentin, even soft dentin, it can remineralize. However, the stepwise excavation takes several months to get the remineralization of callus dentin. Then, how is the clinical result of one-stage selective callus removal to soft dentin in deep callus? There are so many reports that the clinical success rate of selective callus removal to soft dentin is superior to non-selective callus removal. And Mart's group performed clinical trial of partial callus removal, that is one-stage selective callus removal to soft dentin, and stepwise excavation, and compared both clinical success rates. In both 3 years and 5 years follow-up, one stage, the selective callus removal to soft dentin was superior to stepwise excavation. Recently, it was reported the comparison of selective and stepwise excavation in the primary molars for 2 years. The authors concluded that no difference in clinical success rate between them, but total cost in selective callus removal is less than the stepwise excavation. More recently, Portugal group reported that only one session is a better management choice compared to 2 sessions because the cavity reopening procedure is more prone to pulp exposure and highly depends on patient commitment. Getting these reports together in callus removal, firm callus dentin, sometimes soft callus dentin, need to be left to prevent pulp exposure, eventually extend the life of tooth. Then, next consideration is how to maintain the health of tooth, having the remaining soft dentin. The biological approach to the materials is very important, and bioactive materials is very hopeful for this purpose. Then, what is bioactive materials? What is the bioactive? Northern Light Conference stated in 2018 that bioactive materials are materials that cause the formation of reparative tissue or release components that have antimicrobial activity. Furthermore, the materials might be included with a surface conductive to cell attachment and which nucleate the formation of calcium phosphates, including apatite-like materials, when in contact with saliva or tissue fluids. Moreover, the journal Bioactive Materials introduced in their website that it will feature adaptiveness to the biological environment being designed to stimulate and or direct appropriate cellular and tissue responses or control interactions with biological species. So the recently I found and purchased this material from the United States, Parker Bioactive Bulk. This is a bulk fill dual cure composite resin. The instruction said that It released fluoride, calcium, and phosphate ions to stimulate mineral apatite formation and remineralization at the mineral material tools interface. Additionally, it has rechargeability of fluoride ions. Okay, but I don't think it's enough because ion releasing property is the same as the glass animal cement. So 28 years ago, I worked on biomineralization with the late Professor Marza Crenshaw in University of North Carolina at Chapel Hill. Based on this experience, I started to think about biological approach to Caries treatment. My life work is development of multifunctional materials, having mainly the dentin remineralization and regeneration. From now on, let me talk about our research topic and clinical application. After coming back from the United States, I started to work about the functional adhesive material to enhance the remineralization activity of carious dentin intensively. Actually, functional adhesive material possessing not only remineralization activity, but also high adhesive property, high mechanical properties, and antibacterial properties, so-called multifunctional bioactive material. It is desirable. We developed three types of novel adhesive monomers. CMET is a calcium salt of format. It is carboxylate. CMAP is the calcium salt of MEP. And MDCP is the calcium salt of MDP. They are phosphates. Our laboratory established the in vitro mineralization remineralization experimental system. This table showed the composition of the metastable mineralizing solution, the mimic to body fluid. Model decalcified dentin, MDD. This is mimic to carious dentin. And CMET, CMET, FOMET, and FOMETA were incubated in mineralizing solution. This graph results from the mineral induction experiment in mineralizing solution having the saturation of 7.59. X-axis is the incubation time, and y-axis is the amount of mineral formed obtained by atomic absorption spectrometry. The CMET induced mineral formation as same as a model decalcified dentin, but CMET, FOMET, FOMETA did not induce the mineral formation. The interfacial tension of CMET for hydroxyapatite nucleation, which is a good indicator of mineral nucleation ability, is good the value for hydroxyapatite nucleation compared to hydroxyapatite seeding. We measure mineral induction time. In the case of MDD, this is a mimic to the carious dentin. It was 5 hours. For CMET, it was only 2 hours. Compared to model decalcified dentin, CMET induced a mineral formation very quickly. Then the combination of MDD and CMET shortened the mineral induction time to 1.5 hours. According to the result, CMET was suggested to be a strong promoter for dentin remineralization by providing a source of calcium ions. The mineral crystals induced by CMET 24 hours after incubation in a mineralizing solution were plate-like crystals, and they were identified as apatite according to the X-ray diffraction pattern. Summarizing the result, the CMET, the calcium salt of format, has a high potential for apatite nucleation in vitro. In decalcified dentin, CMET can provide a source of calcium ions for remineralization. Next, I will talk about practical research using CMET. In the clinic, resin coating technique is applied to protect the dentin pulp complex in direct restoration. Actually, indirect restoration. It also had the purpose of the improvement of dentin adhesion of resin cement and improving the marginal sealing property of the inlay and crown. It is also used for the hypersensitivity treatment to seal dentinal tubules. The upper material is hybrid coat 2 from Sun Medical as a coating material in Japan. And hybrid bond is a brand name in the overseas market. It is used for hypersensitivity treatment and protect coating of prepared cavity or abutment. The liquid contains acetone, water, MMA, format, and photocatalyst. Sponge or microbrush contains a hydrophilic polymerization initiator. 1.5 CMET and 1.5 MDCP were added to the sponge of hybrid coat to produce the prototype BCA. And we check dentin remineralization activity and mechanical properties of them. Both hybrid coat 2 and the prototype BCA sealed dentinal tubes in the SEM. We can observe some precipitation at the surface of dentin coated by prototype BCA. The precipitation was the aggregation of spherical crystals. We perform an EDS analysis of mineral crystals induced by prototype BCA on dentin surface. The CAP molar ratio of the crystals was 1.32, close to the value of WACO standard hydroxyapatite. So bioactive monomer induced the hydroxyapatite. Next, we check the mechanical properties of prototype BCA regarding shear bond strength to dentin and bending elasticity. Both value in BCA are significantly higher than hybrid coat 2. It is speculated that in the case of the prototype BCA, calcium dissociation from the CMET monomer causes another binding with calcium of dentin apatite and with also calcium of another CMET monomer. So CMET may function as a cross-linker to dentin and other monomers, and the source of the calcium ions for mineral induction also. Also regarding the compressive elasticity and viscous hardness, both value also in the prototype BCA are also the higher than the hybrid coat 2. As summary 2, the prototype BCA, this is a CMET MDCP containing hybrid coat 2. It induced mineral formation on dentin surface as well as complete sealing of dentin. The mineral induced by prototype BCA on dentin surface indicate the similar CAP molar ratio to HAP. The prototype BCA is suggested to be an excellent coating material possessing mineral induction ability and improved mechanical properties. Okay. Then, Biocoat CA, including bioactive monomer CMET and MDCP, was released by Sun Medical in 2019 in Japan. Bio means bioactive. Coat means protective coating. Ca means calcium ions for mineral induction. Additionally, we found that it inhibits biofilm formation by Streptococcus mutans. Biocoat Ca is bioactive monomers containing hybrid coat 2. The bioactive coating material possesses the mineral induction ability and high mechanical properties, including bond strength. Moreover, it has anti-biofilm formation ability. It can be used for caries prevention, hypersensitivity treatment, and dental pulp protection in prepared cavity and abutment. The ultimate caries treatment is seed restoration without any intervention to substrate. The slide showed that developing multifunctional material is critical to establish the seed restoration technique. Next, I talk about the developing bioactive adhesive materials facilitating dental regeneration. We found another possibility of the use of cement as a multifunctional materials. We investigated the effect of bioactive monomer cement on odontoblasts proliferation and differentiation in the cell culture system. Odontoblasts-like cell line MDCP PC23 was used for the experiment. At first, we checked the effects of cement on cell proliferation and viability compared with the calcium hydroxide and MTA. Addition of 5% of every material promoted the odontoblast proliferation. However, cell viability decreased in a concentration-dependent manner. But the viability reducing rate of the cement is lower than other two groups, suggesting its biocompatibility. Regarding the effects of cement on odontoblast differentiation, we checked the odontogenesis-related gene expression in MDPC23 after stimulation with cement. Using the real-time RT-PCR, we found that the cement and MTA facilitated the messenger RNA expression of DSPP and DMP1 4 to 6 times more than the control. On the other hand, calcium hydroxide and also MTA, the promoted mRNA expression of inflammatory cytokines such as IL-1 beta, IL-6, IL-6 beta, and TNF alpha and beta, like that. Then, alizarin red staining data showed that adding 5% of every material induced the mineralization of the MDPC23 odontoblast-like cells. I don't show the data here, but according to the results of selective blockage analysis in signal transduction, we found that the MAP kinase P38 pathway is partially involved in the induction of odontoblast differentiation by cement. Also, we confirmed in that direct pulp capping experiment that cement induced dentin regeneration on 14 days and 28 days in vivo. CMET induced the reparative dentin formation intensively at the early stage of the wound healing with inflammatory uh, less inflammation reaction of the pulp tissue. So CMET process, the CMET has a dentin remineralization activity as well as dentin regeneration activity. Regarding the possible mechanisms of the odontoblastic differentiation induced by CMET, we speculate that the calcium ions released from CMET enters the cell through the calcium ion channel in the cell membrane, and then the phosphorylate P38 to activate it. Or CMET itself may pass through the cell membrane and activate P38, or CMET interact with some other receptors. There are some possibilities. Further investigation is necessary to clarify it. We published these data in the International Endodontic Journal and the International Journal of Molecular Science in 2020 and 2021. Nowadays, there are so many single-step bonding system agents, but no multifunctional one. So recently we prototyped bioactive universal bond. We call this BA bond, bioactive bond, BA bond, including CMET in brush. We compare its properties with clear fair universal bond Curare, Lyman bond universal Dentsply, and Scotch bond universal plus adhesive 3M. At first, we checked the anti-demineralization activity of the BA bond using the old pH cycle test, which we previously published, as shown in this slide. Middle one is 24-hour pH fluctuation patterns of 6 cycles per day from 8 a.m. to 11 p.m. 3 minutes demineralization and 60 minutes the remineralization. BA bond showed low mineral loss compared with the other 3 single bonds. The antibacterial effect of the BA bond was examined using the PMA quantitative PCR method. For Streptococcus mutans, the A. biscoccus and L. casei, the BA bond showed a higher antibacterial effect than other 3 bonds. Okay. Next, we check the odont-brush differentiation ability of BA bond with booster brush. This is BA plus. Without booster brush, BA minus, and Scotch bond universal plus adhesive, SC. Odont-brush proliferation, alkaline phosphatase activity, and odontogenic gene expression and mineralization were checked about 3 materials. 0.5% BA bond, BA plus promoted proliferation, alkaline phosphatase activity, and mRNA expression of DSPP and DMP1, which are odontogenic protein, the odontogenesis related proteins. It also induced the mineralization intensively. Also, 0.5% BA bond showed a significantly higher activity about proliferation, differentiation, and the mineralization compared to Scotch bond universal plus. Okay. As summary, the bioactive universal bond, BA bond showed odont-brush differentiation activity due to CMET. It also showed the deimmunization activity and antibacterial activity. This is the first report to show the multi-biological functions in the adhesive materials. Just yesterday, the paper entitled "The Novel Universal Bond Containing Bioactive Monomer Promotes the Odontoblasts Differentiation in Vitro" was published in Journal of Functional Biomaterials. 2 months ago, the bulk-based hard tool was released as a base material in Japan using our multifunctional technology. Bulk-based liner tool is the same as a BA bond containing bioactive monomer cement in booster brush. It is dual cure bond. Regarding base material, this multi-shade flowable composite resin. There are 3 types of viscosity: high, medium, and low flow. Resin composite that shows low polymerization shrinkage, about 2.7%. So we can do bulk filling to 4 millimeter thickness for light cure. Also, this material can be used for regular composite resin restoration. I show you the clinical use of bulk-based hard tool as a base material in CAD/CAM in the restoration. Patient was 70 years old male. Chief complaint was discomfort when touching the surface of number 24 with the tongue. Yes, there are the deteriorated restoration at OD surface of number 24. After removing the restoration, the selected caries removal to firm denting SRFD was performed. Cavity is a little deep, so the base was necessary. Applying bulk base liner tool using a booster brush and air blow and LED light cure for 5 seconds. Filling the bulk base hard tool using medium flow resin into distal cavity and light cure for 10 seconds. After the base, the cavity form was collected and cavity preparation was finished. And took the impression. At the next visit, after adjustment of the contact point, the applying M1C primers, this is a the saline coupling agent, to adherent the surface of the hybrid resin calcium inlay. Adhesion of the calcium inlay using the superbond EX universal was performed. Finally, the completed the restoration after occlusal adjustment and polishing. Next case is composite resin direct restoration by bulk-based hard tool. Patient was 20 years old male. The chief complaint was cold pain of number 36. There was a hidden caries at occlusal surface of number 36. From visual and X-ray inspection. This time also the selective caries removal to firm dentings SRFD was performed using caries detector dye. Applying bulk base liner tool using a booster brush, bulk feeding of bulk base hard tool into the cavity, and the light cure for 20 seconds this time. Finally, the completed the restoration after occlusal adjustment and polishing. In both cases, aesthetic restoration were performed and long-term follow-up will be performed for the checking the pulp response. The pulp response, the denting condition and also the restoration, the conditions. Okay, it is expected that the CMET showed antibacterial activity and induced the remineralization of decalcified dentin. Moreover, it is possible that CMET penetrates dentinal tubes to pulp tissue to induce reparative dentin formation intensively. So we can avoid any risks to pulp exposure from many points of view using this kind of multifunctional bioactive materials. Finally, using this schema, I want to say that the further improvement of dentin adhesion and mechanical properties, and also optimization of each function will make it possible to develop novel caries treatment methods, increasing the predictability and certainty of the treatment. Then we can realize the real seed restoration in near future. Okay, I appreciate these people's significant contribution to the project. Now, this is a scenario of Sapporo City. This is a scenario of the Sapporo Snow Festival held in February every year. This is very world famous festival. This year it was held after 3 years of cancellation due to Corona, COVID-19. We have many sightseeing areas in Hokkaido. So please visit our university along with traveling to Hokkaido. Thank you so much for your attention.
Thank you very much, Professor Saito, for the very informative lecture. And it's great to see a lot of work has been done in the work that you have carried out. So we have about 4 questions in our Q&A. The first question is from Mr. Dr. L. Babu Gupta. He asks, can we use our caries remover in all caries teeth, either superficial epidermal caries or in deep caries teeth?
Oh, okay. Thank you so much for the question. You mean the caries remover means caries detector dye, right?
I guess so.
Right.
That's what.
Okay. This is used for only the dentin caries dentin, not enamel. Okay, because the mechanism of the staining the caries region by the caries detector dye is just penetrate of the dye into the porous structure due to the decalcification by caries. So only the dentin caries can be used for the dentin caries. Okay, so because after the decalcification, the collagen network is exposed, so we can use only the dentin. Thank you very much.
Okay, thank you.
Okay,
Saito. Another question from Chen Ling.
Okay.
He asked, Prof, can hybrid coat be used on sensitive roots that have been exposed from gum recession?
Oh, yeah. Thank you very much for the question. Yes, hybrid coat or the BioCoat CA we developed, both of them can be used for the occlusion of the dentinal tubules. Okay, so we can use the dentin, of course. But in case of cementum, yes, we can seal the surface of cementum also after resection of the gum. So to prevent the root surface caries occurring, or the removing, the expose the dentin structure. Okay, so we can use both of them. Thank you.
Okay, thank you very much for the
Thank you very
answer,
much.
Dr. Khan. For the third
Okay.
and fourth question, we have
Okay.
in our webinar one
Okay.
of the council member for ICD, Professor Bedros Saku. I will let him ask personally to you the question. Professor Bedros?
First, I would like to thank and congratulate Professor Dato Mohamed Ibrahimi for very interesting, let's say, presentation. And thank you, Professor Takashi Saito, to present the future of dentistry. That's the future I call, because, you know, this technology and the material used, they are modern materials, and your research and knowledge will enlighten our practice, everyday practice of dentistry. So I wanted to ask you if we completely eliminate the dical, the calcium hydroxide that we used to use, and we use still in some countries, and I would like to know that for the deep cavities, do you recommend still the use of calcium hydroxide or not?
Okay, thank you so much for kind comment and the questions, Professor Bedros. Thank you. Actually, I don't refute the using the calcium hydroxide. You mean the dicar, right? For the deep caries region.
Yeah.
The calcium hydroxide is very good material. Also the MTA, also good materials. But this is a fact that there are some defects of the materials. Some researcher reported some defect of the calcium hydroxide. High alkalinity give the damage to the pulp tissue sometimes, like that. Yeah. So we want to develop the biocompatible materials in near future. So someday, I hope we can take the bioactive material take place of those materials for the biological treatment. Okay. So I never refute deny this kind of materials, but we can improve the material in near future. Thank you.
Yes.
Thank you so much.
I believe in, let's say, sealing the dentinal tubule to prevent infection and to prevent sensitivity, which is very important. And
Yes.
I would like, if this bioactive material can do that function in case of affected dentin at the really very deep and close to the pulp cavities. If we leave a layer of affected dentin and we put the bioactive, let's say, liner or bonding or material, filling material, is there still activity through that affected dentin to reach, the base layer of the cells that they produce, the reactive dentin?
Yes. Yes, I agree with your comment. Totally agree. Actually, I hope the cement penetrate the dental tubes to the pulp chamber to induce the reparative dentin intensively and protect the pulp tissue. Right. Thank you so much.
Thank you. And another thing, if I may, let's say you mentioned 2 sessions for the same cavity. Let's say the patient comes and it's a very penetrating cavity, and you do it at the first step, you fill it, and 6 months later, 1 year later, whatsoever, to open again. How to handle the situation with the patient? How many times the patient has to pay for the same cavity?
Actually, excuse me.
Let's say
Your question is the
you treat twice.
okay.
You know, the
yes,
two
in two,
sessions.
right, stepwise.
The
Right.
first section that you prepare the cavity, you place the
Yes.
bioactive material, bioactive filling material,
Mhm.
and after that, 6 months later, again the patient comes, again you open the cavity, again you
Yes.
use the bioactive material. How
Right,
many
right.
times the patient has to pay, you know, for the cavity, for the same cavity? Do they pay once or twice?
Actually, twice. Actually, twice.
Okay.
So I showed one paper that they reported that the selective caries removal one session caries removal has a good cost performance compared to the stepwise excavation, right? So
Yeah.
yes. Actually, in Japan, one step the selective the caries removal to soft tissue is not popular. How is it in your country?
Let's say if it's very close to the pulp. By the way, this morning I had a patient and I treated, it was very deep. So I just removed whatever you were talking about by not reaching the pulp and to give to the pulp the chance to react. And I placed the dical, and after that, the base material, and then I did the final filling. And if the patient has further pain, discomfort that continues more than a couple of days, then that will be root canal. If it stays without symptoms, without any pain, so the feeling is good and it stays like that, and I don't have to go into again the cavity and to do it. But I'm looking forward, based on your presentation, your lecture, to use the bioactive material soon, you know, hopefully. And thank you very much. Thanks.
Okay, thank you.
Very, very
Thank you.
good presentation.
Thank you so much.
Thank you very much, for Badros. And Prof. Saito, there's another question.
Okay.
It's initial ZHK. If the question is, thank you, Prof, for the informative lecture. Is hybrid coat compatible with other brands of composite?
Oh, okay. With other brand of composite. Okay, hybrid coat or BioCoat CA is it is a sealing materials for the hypersensitivity treatment, but it can be used as a just bonding agent, one-step bonding agent, right? So yes, I don't understand what he means exactly, but
is hybrid coat compatible with other brands? I'm not
sure. Right. Hybrid coat is yes, compatible with.
I mean, maybe hybrid coat can be used with all brands of composite, maybe.
Right. Oh, I see. Okay, I see. I understand. Okay, now. Okay, yes, any composite can be used for the hybrid coat CA, right?
Okay.
So hybrid coat or BioCoat CA, no, any composite is fine, right?
Okay. All right. Thank you. I think one last question, Professor Saito. If I think your talk is very interesting, so we have many questions tonight. It's from Dr. Nuzulia. She asks, can Caries detector dye act as an antibacterial and soften Caries dentin, so the infected dentin can be easier to remove?
Oh, okay. Maybe he mentioned about Caries solve, some the agent to the, I mean, the, yes, sorbent of the Caries lesion, but it's not the same. Okay, Caries detector dye has not any effect for antibacterial effect or some effect, and not soften dentin caries. So just we can use this dye for the identify the checking the infected dentin. This is infected or affected dentin, right? So the and also it doesn't stain the bacteria, okay? Just it's stain the collagen fibrils exposed after the demineralization of the dentin. So maybe he is mentioned about the Carisol, the chemical, the solvent of the Caries region, right? Okay, thank you so much.
Okay, thank you very much, Prof. Saito. I think that's the last question for our webinar tonight. And again, on behalf of organizing committee, myself, Dr. Amy, Dr. Mayuna, and Dr. Nagam, who is the committee for discussion committee, would like to thank you for sharing this very informative lecture with our audience. And at the peak of the webinar tonight, we have about 70 participants who have logged in to listen to your talk. Congratulations, and on behalf of the IDCD Section 15, we would like to thank you again for the presentation tonight. Thank you, Professor Saito. Hope we can meet again sometimes in future, and I look forward to meet you in person next week. Next week at my school, next week. Okay, all right. Thank you. And as usual, I would like to announce that for next month. Sorry, we are not able to prepare the brochure in time because we just got confirmation that next month the lecture will be from the Dean of University Malaysia, Professor Dr. Zamri. He's an orthodontist. So he will talk about orthodontics, and we will announce the exact title of the presentation by next week. Okay, so we meet again on our next webinar in November, 15th of November, with Professor Zamri Radhi, the Dean, Faculty of Dentistry, University Malaya, on orthodontics. Again, tonight, thank you very much for listening. Thank you for Bedros for joining the tonight webinar, and see you all next week. And thank you, and bye-bye to all. Okay, thank you.
Thank you very much.